It gives me great pleasure in introducing Dr. Mohamed Babiker, who is a department head and consultant pediatric neurologist at Jalila Children's Speciality Hospital in Dubai, which is a tertiary quaternary center for us. He's going to talk to us about the rare dystonias. Never miss a therapeutic opportunity. I always tell my colleagues, if you have a child who is not doing what you want them to do in terms of movement, send them to this man. So, Dr. Mohamed Babiker, please.
Thank you very much, Jai, for the very nice introduction, and thank you very much for the nice and kind invitation by the organizing committee. Thanks for the audience for being here on Sunday morning. So, the next 20 minutes or so we'll be talking about rare dystonias, and there's just quite a few take-home messages that I'd like you to take away from my talk. Is since we're in a rare disease conference, we just want to make sure that we're not missing the rare and the treatable conditions that we come across in our clinical practice. So, the objectives from this talk, just to recognize the definition of dystonia. I know most of you are experts in this field and you know exactly, but just it wouldn't do any harm to just go through the definition of dystonia. What do we mean by when we say the word dystonia? Its clinical features and the pathophysiological mechanisms, and also to discuss some of the rare genetic types of dystonia and recent advancements with focus on treatable types, and also to discuss, again, just a bit of an overview about the management challenges and the future developments in this very exciting and fascinating field. So, dystonia is defined, so this is pretty much the most recent definition, which was agreed upon by a group of experts in the field in 2013, whereby they define dystonia as a hyperkinetic movement disorder. And when we say the word hyperkinetic, it means that you have a lot of movement. And it is characterized by sustained or intermittent muscle contractions causing abnormal and often repetitive movements, postures, or both. As you can see in this child, who was a 4-year-old girl with dystonic cerebral palsy, which we're all familiar with. You can see the abnormal positioning, the abnormal posturing, and you can see the intermittent, sustained muscle contractions that this child is going through. And again, we're very familiar with these types of abnormal postures, and unfortunately, if dystonia is left untreated for a long time, eventually we get a lot of musculoskeletal deformities, as you can see here. And it pretty much affects every single muscle in your body, you know, limbs, feet, the neck, as you can see here, the spinal column, and it's just very, very, sometimes very distressing to see these patients going through all these awkward and rather painful looking postures because of the dystonia. To make life easier and to just make life simpler, dystonia is just a combination of abnormal movements, as you can see here in the video on the right, and also abnormal postures. Okay, this is the same child just sitting in her mommy's lap, and you can see, you know, somebody might say, "Oh, this child has a scoliosis." But I can assure you that this child does not have scoliosis. So this apparent curvature in her spine is because of the dystonia. The moment she goes to sleep, the moment her dystonia disappears, her spine becomes straight. So, dystonia, abnormal movements, plus abnormal postures. So, going back to basics, how do we move? I've always wondered since I was in medical school, how do we move? And the best analogy that I could come across is moving your car. We all came here driving our cars. So how does this happen? In order for you to drive efficiently and swiftly and smoothly, it's a function of two things, isn't it? The accelerator and the brake. And you have to keep that balance right between accelerating so that you can speed up, but equally, you have to use the brake so that you don't swerve and you don't go into accidents. Now, if we apply this in real life, and if we look at the human brain, and if you look specifically at the level of the cortex and below at the level of the deep basal ganglia, you get something like this. So It looks a bit complicated, but I promise you, it's very simple. So you get initiation of the motor orders coming from the cerebral cortex. They come down through the striatum, the globus pallidi, and the subthalamic nucleus, which are part of your basal ganglia. Okay, and then you have inhibitory input coming from these basal ganglia to modulate the movement, so that we can get swiftly fine tuning of our desired motor pattern. So this is in the normal state. So now I'm moving my arm, I'm applying exactly the same kind of circuit. And that's why the movement appears to be smooth and fluent. Now imagine if we come through these inhibitory signals, and then the desired motor pattern becomes impaired. And this is exactly what we see in dystonia. So dystonia is primarily caused by loss of inhibitory control coming from the basal ganglia, and not just only the basal ganglia, the complex networks that they're part and part of. Again, this is a very simplistic way. It's more complex than this, but this is, at least for me as a simple-minded neurologist, this is how I look at dystonia. And as a result of this loss of inhibitory control, you get the groups of muscles that are supposed to relax and contract at the same time, working simultaneously at the same time. So if I want to flex my elbow, my agonist and antagonist work simultaneously at the same time, and this will be manifested as dystonia. As you can see here, this young man with a primary type of dystonia, you can see the twisting, you can see, he looks like he's a bodybuilder, but that's just because all his agonist and antagonist muscles are working simultaneously at the same time. And imagine life living like this 24/7. Must be pretty hard. So, how do we classify dystonia? What causes dystonia? Again, in very simple terms, I usually look at it as secondary dystonia or primary dystonia. And when I say secondary, we've seen very nice MRI scans this morning. The brain MRI scan is usually abnormal, like in this case. So this is the case of cerebral palsy following neonatal hypoxic encephalopathy. And as you can see here, the arrows doesn't show very well, but you can see there is damage to the globus pallidi, to the putamen, and to the thalamic nuclei. So that is why this patient will be having a dystonic type of cerebral palsy. And this is by far the commoner type of dystonia that we come across. On the other hand, you have primary dystonia, whereby the brain MRI scan is normal, and then this is the time when we should be thinking about genetic causes. And this is the time when we should be looking for doing genetic testing on these patients. And actually, this field has just been expanding, and it just keeps expanding. You can't really keep up with the explosion of knowledge that we know about monogenic dystonia. So this is a recently published paper on a large multi-center study where they actually looked at all the genes that have been described to cause dystonia. You can just see, it's a very busy slide, but this is more than 100, 120 genes that have been implicated in primary dystonias. And this is from the same paper. Apologize, it's a bit of a busy slide, but the take-home message is about 1/3 of monogenic dystonias are actually amenable to treatment. You can do something about it. Okay? If you take one take-home message, do genetic testing, look for 1/3 of patients with primary dystonia that you can actually change their lives. So this brings us to this very topic that is dear to our hearts as neurologists, that genetic diagnosis in patients with dystonia can actually help guide treatment. So how? We know that we can offer a lot to these patients if we diagnose them. We can give them some dietary treatments, like ketogenic diet, for example, or supply them with certain vitamins, like in the case of biotin thiamine basal ganglia disease. We can offer them surgery in the form of deep brain stimulation. We've seen very nice talks throughout this conference about novel drug therapies, about gene therapies. We can use specific medications that targeting specific synaptic areas in the brain, like in the case of carbamazepine, which is used to treat PRRT2 dyskinesia. We can use dopamine where we think there is dopamine deficiency. we could help reduce the toxic molecules in the case of Wilson's disease, where they have accumulation of copper, so there are available genetic therapies that we could use. And the list goes on and on and on. The question that I always get asked, I always ask myself, why do I need to treat dystonia? Because dystonia is a very disabling condition. And this has been backed by so many studies. And this was a nice article which was published 2015 by a group from London, where they interviewed children and caregivers and children themselves who have dystonia. And look at this, 38% of their cohorts, patients with dystonia, they were reporting pain. Okay? Difficulties and activities of daily living was features in about 25% of these patients. Difficulties with hand use that you and I would take for granted, we don't even think about it. If I'm scratching my head, I don't even think about that. These patients cannot do this in 21% of the times. Seating, you're all sitting there very comfortably. Imagine if you have dystonia, would you be able to sit as comfortable as you are now? So these are things that we probably need to address. I came across this quote, which is really quite moving, and I think it seems very relevant to this type of conferences, which goes like, the world is full of pills, but medicine is rare. The world is full of stethoscopes, but listening is rare. And I think we as doctors, we as nurses, we as healthcare professionals, we should always listen to our patients. We should always listen to our colleagues. We should always listen to our patients, telling us what their concerns are and trying to address these concerns and try to help. I'll just spend the next few slides telling about some stories from the real world. And this is a mother who brought her girl to see the pediatric neurologist, and she had one question in her mind, which was, why does my child have cerebral palsy only in the evenings, doctor? Which was a very good question. And the story goes like this. So this is a 7-year-old at the time when she was seen. She was diagnosed by her local pediatrician as a case of cerebral palsy, despite the fact that she had normal perinatal history and her initial early development was absolutely normal, and she had normal brain MRI scans. But mom wasn't convinced about the diagnosis of cerebral palsy. She was treated as such. So the neurologist, so this is her story in a nutshell, and this is before she got the treatment. So this is how you can see the her dystonia, especially in the lower limbs. And this is a girl who was given a diagnosis of a diaplegic cerebral palsy. She wasn't able to walk, okay? She wasn't able to stand. She seemed to be in a lot of discomfort, a lot of distress. And this is a girl that the mother will tell you, when she wakes up first thing in the morning, she's usually okay. She doesn't have cerebral palsy. Only when she comes back from school, her cerebral palsy starts appearing, which was very unusual. Despite that, people insisted that she does have cerebral palsy. Okay? And based on this presentation, and you can see, so this is her coming back from school, and she has to be carried by her mom. Then the neurologist said, okay, I'll start you on a medicine, which is levodopa. Mom said, oh, but this is a medicine used for Parkinsonism. He said, yes, use it. And this is the result. Just only a few days after she got started on the treatment, she just looks like a very normal child. And her cerebral palsy went away, meaning that she does not have cerebral palsy, obviously. So, you probably figured it out now by now. This is a case of dopa-responsive dystonia, otherwise known as Segala disease. And quickly, it's commonly due to autosomal dominant guanosine triphosphate cyclohydrolase deficiency. It usually leads to progressive dystonia. Typically, in about 75% of the time, these patients may have latent variations because their dopamine stores are at their best when they wake up in the morning, and as the day goes through, the dopamine stores get depleted, and usually responds very well to low doses of L-dopa. CSF neurotransmitters, start them on dopamine. That usually helps. Another case, can you please see this boy with speech and ear difficulties? All tests are negative. It's a case who was referred to me a few years back. And this is a 6-year-old Emirati boy, was violent until the age of 3 years, then he started limping, and then lost ambulation, and then effectively he started to have ascending dystonia with upper limb involvement later on, and also speech deterioration. He had normal brain MRI scans repeatedly, and whole exome sequencing, none at the time was showing a variant of unknown significant, which wasn't really significant in his case. And this is him when I first met him about a few years back. And you can see he's struggling to talk because of the facial muscle dystonia. Not because anything to do with phonation or anything like that. And could you fast forward the video, please, and the rest of time? You can see the lower limb dystonia there. Yeah. And then we ask him to walk. He looks very hesitant to walk. Okay? And he wouldn't. He would just fall, he would just trip. Okay? Fast forward, please, just a little bit. Yeah. So this is him. He can't really walk. So the anecdote here was there was one of the conferences which actually the senior author of this paper presented their findings of a newly described gene called the KMT2B. And when we read this paper, it was actually very fitting into this child's phenotype. So we said, okay, let's request the whole exome sequence again. And this time around, we provided the lab with much more information, probably, maybe more proper phenotyping. And we said, could you please specifically look at the KMT2B gene? And the result came back, confirming our suspicion that this child had KMT2B gene mutation. And not only that, the exciting news was that this case was actually, this disorder is actually amenable to treatment, and they usually show good response to deep brain stimulation. So we persuaded the family to travel abroad to get treatment for the deep brain stimulation. And this is him just only a few months after he came back from the deep brain stimulation. And I will just show you, so his speech is still not great, but look at him now. He can walk independently. He can do a lot of things that he wasn't able to do before. And that's because we diagnosed him right. Sorry, I say we, but he was given the right diagnosis, and he was offered the right treatment. So I will just skip quickly the rest of time. This is a teenage girl who came to the doctor complaining of her legs giving way and her feet getting stiff after she runs. And this is a girl who has mild learning difficulties. She was diagnosed with ADHD, and then she was asked to run for about 50 minutes or so. She's running fine, but as soon as she finished running, this is the way she's walking. Her brain MRI scan was normal. She underwent a Doppler puncture, which showed a very low CSF glucose with a low CSF lactate, and her dystonia gene panel showed a pathogenic mutation in the SL2A1 gene, which gave the diagnosis of glucose transporter 1 deficiency, which was presenting with exercise-induced dystonia. And the question that she asked, now doctor, you know what's wrong with me, is there any treatment? And the answer was yes, go on the ketogenic diet. And she did, and her symptoms improved. Okay? Again, I'm not going to talk about this, just in the rest of time. I will just finish with this last case. And this is a boy who said to the doctor, doctor, my body keeps twisting and I cannot stand upright. Okay? And this is a boy who started with, who presented with progressive walking difficulty from around the age of 6 years, had remarkable past medical history, he had normal brain MRI scan, and he was found to have, a genetic mutation in the TOR1A gene, which gave him the diagnosis of DYT1 dystonia. And this is him. I'll just play the video. Sorry, can you play the video? Sorry, I know I'm a little bit overrun this time, but I promise So this is him before the operation. And he just keeps his twisting, abnormal movements. He can't really do much. You can see the hyperkinetic movement. This is a case of dystonia. Can you play forward to the middle of the video? A little bit more forward. And this is all before the operation. Okay? You can just do the very last. Yeah. And this is him after he was offered the treatment for deep brain stimulation. It's a life-changing thing. It's a life-changing procedure that he underwent. Okay, so take-home message. I hope I have convinced you that dystonia is disabling. Timely genetic plus other targeted testing in dystonia can potentially improve the management outcomes. Better clinical, radiological, and biochemical phenotyping can lead to better genetic testing. I think that's important. And about 1/3 of monogenic dystonias are potentially amenable to treatment. Please, let's try not to miss them. And with that, I finish. Thank you very much.
Time for 2 questions. Anyone from the audience?
I would like to know, would you give a DOPA before CSF testing?
Yes, yes.
Do not wait for...
No, absolutely, because it's a widely available drug. You can find it anywhere. You just start with a small dose, maybe up to 5 mg per kg, and then just wait and see if they have dopa-responsive dystonia. That's almost diagnostic. And if you can see a vast improvement, that's almost a diagnosis.
There's a question, sir.
Oh, just a short comment. I'm on the receiving end of your samples when you send out for genetics.
Oh.
It would be very helpful if you send samples of parents with them.
Yeah.
The pickup rate, the diagnostic rate of a trio is 10 times more powerful than a single exome.
Yes.
So if you do order those genetic tests beside the proper phenotyping, it would be helpful if you send out
Absolutely.
parent samples.
Absolutely. Thank you.
Just to comment there, one of the satisfying thing as neurologists, as trainees in neurology, and even after that, was prior to the whole exome sequencing, was when you suspect a condition, you line the phenotype, and you suspect that this probably is spastic paraplegia or something, and when it comes back, it gives you that satisfaction. Now we have an umbrella that we just throw out, and we catch a fish in the pond, and then in one way we've lost that. This thing is
Yes.
push ourselves
Yes.
to get the specific diagnosis.
Yes.
But it's an extremely exciting field because the genetics has encompassed pretty much every neurological condition that we were not sure about. And if for a trainee taking up pediatric neurology at this point of time, there's never been a better time than after this. Yeah. But thank you so much for the talk.
Thank you.
We just have to post a photograph.
One question about
Oh, sorry.
it's a very good presentation. It's other referred to actually one question that they said actually whenever in doubt or when you don't have the diagnosis of dystonia, start the better. And
Yes.
because there is a honeymoon period. So if you don't have the diagnosis, and how long this honeymoon period can?
For the response to dopamine. So see, my practice is usually I give L-dopa and I wait for about 4 to 6 weeks. If I see an improvement, and sometimes it can be very helpful to ask the parents to take videos before the treatment, on week 1 or week 2, so that it gets a bit of a timeline. And if you are convinced that they are fully responsive, or at least partially responsive, you know that you're on the right track. If they haven't responded within 4 to 6 weeks, or sometimes up to 2 months, then they're very unlikely to respond, and they're very unlikely to have a dopa-responsive dystonia.
Thank you.
Another thing is that many times, because we see these patients with dystonia along with this dystonia due to many conditions.
Right.
So what would be your approach in those conditions, which are actually there are 2 different conditions?
Yes.
What mechanism?
Yes. So my treatment approach would be treat dystonia first, and then look at the other movement disorders. Because dystonia, as we've seen, is more disabling. And so kids will live happily with their choreoacidosis, but dystonia can be quite distressing for them. So aim to treat their dystonia. And if they're left with a little bit of choreoacidosis, you have to compromise with that.
Thank you. For the sake of time, we have to move on.